for whom I am new. I am Dr. Praveen. Actually, I am a bit familiar to these type of questions. Okay, I cracked AIIMS 3 years back. So, इस AIIMS में, particularly for the just before class PSM, you would have come across many new type of questions. Thankfully, for pathology, we have very straightforward questions. And what I have given, every reference from pathology is from Robbins. What it means that if you read Robbins, you can solve 100% of questions. Not a single question is out of Robbins. Not a single question is out of Robbins. In pathology, every 20 questions is from Robbins. Okay. Sir, what remote? Okay. Well, this question must have been the first question of many of you. सबने appear किया था AIIMS? Everyone? Okay. So a person is having painless lymphadenopathy on biopsy binucleated owl-shaped nuclei. But this comes to a question, what comes to your mind? Reed-Sternberg cell. Okay. With a clear vacuolated area. Now what is this? Clear vacuolated area. If you would have attended the audio-visual class, I showed you this. Well, some of you left, but for some of you actually appeared in this class, clear vacuolated area around a Reed-Sternberg cell. I told you this is an artifact, if you remember. I told you this is a nodular sclerosing variety. The diagnosis is right in the third line. The diagnosis is right made in the third line. A Reed-Sternberg cell surrounded by a clear vacuolated area is a morphological finding seen in nodular sclerosis. Let's read the question again. With CD15 and CD30 were positive, what is the most probable diagnosis? Well, 15, 30 positive. We are not talking about the B cell markers. CD20 we are not talking about it. 15 and 30 means we are into the Hodgkin's disease. Well, Hodgkin's disease code WHO ने 2 part में divide किया था. We discussed this. It is classical and nodular lymphocytic predominant. Okay, because they behave differently. What is there in the nodular sclerosis? Now these are what we are talking about, the clear space area. These are the artifacts which are formed during the cutting of the section. This artifact in which there is a Reed-Sternberg cell situated is a prominent feature of nodular sclerosis variety of Hodgkin's disease. Okay, 1530 is positive, which comes in all variety of classical, unlike nodular lymphocyte predominant in which CD is positive and 45. Okay, so the diagnosis is quite clear. If you get CD15 and CD30 as positive, CD15 and CD30 as positive, you are talking about classical Hodgkin's disease. And when you get a CD45 positive with CD20 positive, you are talking about nodular or lymphocyte predominant Hodgkin's disease. Well, large granular lymphocytic lymphoma, it is not a Hodgkin's disease. It is a non-Hodgkin's disease. So that is excluded. Lymphocyte depleted में, the question would have been a person suffering from HIV or an immunocompromised person. This would have been the typical history. It is important to note that usually the nodular sclerosis are Epstein-Barr virus negative. This is a very, very important MCQ. Nodular sclerosis variety of Hodgkin's disease is Epstein-Barr virus negative, while the lymphocyte depleted variety has 90% positivity of Epstein-Barr virus cells. So the diagnosis or the question for this answer is nodular sclerosis type of Hodgkin's disease. Quite a simple question. Most common NHL in lymphoma. TND, I think I was with you. Diffuse large B-cell lymphoma. This was the question that was also in the TND. Most common non-Hodgkin's lymphoma is diffuse large B-cell lymphoma. I told you every organ in the body has the most common lymphoma of NL, that is diffuse large B-cell lymphoma, except stomach, which is maltoma. Very good. Please remember this point. Every organ in the body has the most common lymphoma of diffuse large B-cell lymphoma, DL, BCL, except stomach. जो क्वेश्चन आया था May exams में. The most common lymphoma in stomach is, it is B cell maltoma. Okay? That orbit में भी सर NLBCL होता है, DLBCL होता है. DLBCL. Exactly, DLBCL sir. Follicular lymphoma. Okay. Second most common type of lymphoma is follicular lymphoma. Remember this point. कभी ये भी हो सकता है कि DLBCL आपके choice में ना हो, and then you will have to trust on follicular lymphoma. Anaplastic large cell lymphoma is a very rare and is very malignant, and large T cell leukemia lymphoma mostly presents with a mediastinal mass. So the answer is diffuse large B cell lymphoma. Now because you would be appearing in NEET exam in a few days, I have a picture for you. Well, it is difficult for you to identify it, but at least if you get a similar type of question, you get a lymphoma and the biopsy has been shown. Very large cells with a vesicular pattern. It can be DLBCL, that is diffuse large B cell lymphoma. Morphologically, they are large cells and a prominent nuclei. They are large cells with a prominent vacuolated nuclei. Remember this. Okay? So the most common lymphoma again is DLBCL. Moving to next question. About CML in children. Well, if you remember what I told you, in CML, the diagnosis should be... Okay. Still discussed, so we can just skip it. But remember, BCL is very positive, and this is the Philadelphia chromosome with a long arm translocating with a long arm of 922. So drug of choice is protease tyrosine. So as discussed it, so we'll not discuss it. I'll move ahead. Platelet is attached to collagen. T and D, my first question. It is von Willebrand factor, and this is the endothelium over which there is the collagen. These big drops are the platelets. The platelets are attached to this collagen by glycoprotein 1B. I told you 1 is first, so the main function is addition. And if this is deficient, it causes either von Willebrand factor due to von Willebrand factor deficiency, or due to a deficiency of GP1B, it will cause Bernard-Solier syndrome. A very simple question. Similarly, if 2B3 is absent, platelet aggregation will not there, and the disease will be Glanzmann thrombasthenia. Now this can be a very, very important question in NEET. One question from clotting if comes will definitely be on this diagram. Remember this diagram. Given in Robbins, you can write down the page, it is page 116, 8th edition. Okay, a 16-year-old Afro-American boy presenting with a non-healing ulcer of the foot. Afro-American, those who have read Robbins, उसमें ये word लिखा हुआ है, Afro-American. I am telling you, read Robbins very carefully or tell your juniors to do so. Afro-American boy presenting with a non-healing ulcer of foot with recurrent pneumonia, chronic hemolytic anemia. Where are we? We are into sickle cell anemia, okay? The peripheral blood erythrocyte showed some peculiar appearance. Well, it was also shown in the audiovisual that this peculiar appearance is of the blood cells going to sickling appearance. Okay. Now, why does a sickle cell anemia produce recurrent pneumonia? Because of vaso-occlusive symptoms. Why does it cause chronic hemolytic anemia? Because these RBCs, when they pass through the spleen, they do not get modified. In that process, the spleen destroys it, which causes hemolysis. And non-healing ulcer of foot is again due to the infections. So, of course, most likely causes, it is single amino acid base substitution, that is at the 6th position, glutamic acid to valine. A very simple and short forward question. So point mutation at the 6th position of the beta globulin causes this feature, and the most common features are initial splenomegaly followed by autosplenectomy. Okay. Well, this diagram is what you just saw in the audiovisual class that you attended, which is not a feature of megaloblastic anemia. This is probably a repeat from the May exam, if you remember. Mild splenomegaly. Now, why does this appear? If you remember what I told you in the T&D, in megaloblastic anemia, there is ineffective erythropoiesis. Bone marrow is cellular, but there is pancytopenia in the peripheral blood. Why does that occur? Because the blood cells that are produced are not normal. Okay, they have deficient B12. So as soon as they come in the peripheral blood, they get destroyed. So a mild degree of hemolytic anemia is always present in megaloblastic anemia. Did you get this? A mild degree of hemolytic anemia will always be present in hemolytic anemia due to ineffective erythropoiesis. Remember this word, ineffective erythropoiesis, which also causes basophilic stripling, if you remember that. So mild splenomegaly will be due to the hemolytic episodes, the ongoing hemolytic episodes, because the RBC are being destroyed where? In the spleen. That will cause mild splenomegaly. Increased bilirubin, of course, due to the hemolytic anemia, there will be increased bilirubin, mostly indirect. Increased NRBCs. There always occurs, due to hemolysis, more amount of production of the nucleated, that is juvenile RBCs from the bone marrow. But because it is an anemia, so reticulocyte will not be seen. Of course, reticulocytosis is only a feature of single anemia, that is hemolytic anemia. Mild hemolytic anemia will not cause reticulocytosis. It can cause NRBCs. So the answer here is reticulocytosis. What are the other features? If you are asked the most characteristic feature of megaloblastic anemia, it will be macroovalocytes and hypersegmented neutrophils. That is, more than 5 lobes of a neutrophil is a feature in megaloblastic anemia. In iron deficiency anemia, probably this was a very controversial question that was asked in this AIIMS. In iron deficiency anemia, all of the following are true except latent iron deficiency anemia is the most common presentation in India. Transferrin saturation less than 16%. Serum ferritin is the earliest marker. It can present without detectable abnormalities. I know many of you would be just thinking about transferrin receptors. I don't know why. I told you very clearly, this is the table direct from Winthrop's, from which the question has been taken. Now, iron deficiency anemia presents in 3 stages: pre-latent, latent, and anemia. If you see very carefully, just important differences are, in the anemia stage, hemoglobin and MCV is reduced. When this is not reduced, it is either called a latent or a pre-latent. But the first, remember, the first marker to be reduced is ferritin, and it is not and never transferrin receptors. I told you, serum ferritin is the most sensitive marker for iron deficiency anemia. But when you are talking about the response, then you can see transferrin receptors. So serum ferritin is the first thing that is reduced, and that is in the pre-latent stage. Okay? So one option is correct. Serum ferritin is the earliest marker for iron deficiency anemia. Clear? Okay. Latent anemia is one in which hemoglobin and MCV are normal. But in India, what happens? Mostly of the people who present are presenting with anemia. There's a difference between iron deficiency and iron deficiency anemia. Iron deficiency anemia means the third stage, in which the hemoglobin has reduced. The first 2 stages mein hemoglobin is normal. So if you again look back to the options, of course, first option, latent iron deficiency is most common presentation in India. It is not so. Iron deficiency anemia is the most common presentation in India. Latent is not. Because latent mein hemoglobin and MCV will be normal. Okay? Transferrin saturation is less than 16%. Of course, it is a true option. Serum ferritin is the earliest marker. We just saw it is the right option. It can present without detectable abnormalities. Of course, it can present with any detectable abnormalities. So the right answer here is latent iron deficiency is the most common presentation in India. Remember this. Okay? This is what you can get in a NEET exam. Plenty of microcytic and hypochromic. These are the cells with full hypochromia that can be seen in iron deficiency anemia. Remember this diagram. If you get one diagram from pathology, it will be microcytic hypochromic picture of iron deficiency anemia. Pure red cell aplasia is associated with all except. This unfortunately was also taken from the direct table of Winthrop's. Well, ABO incompatibility after renal transplant, 5q syndrome, drugs, and large granular lymphocytic leukemia. This is also given in Robinson. What is pure red cell aplasia?